Good evening, doctors and all the participants. I Shuman on behalf of Shield Healthcare, welcoming you all in today's session. And it's a new webinar series, Prayas on common gynecological issues. And the guest speaker is Dr. Jyoti Bunglowala, madam. And the topic of discussion is a very important and emerging topic, that is understanding menopause and its management. So again, it is obviously in our platform, Shield Connect, which is basically a knowledge sharing platform of Shield Healthcare. Let me introduce this unique platform, which is specially dedicated to our medical science. And this is the blog section you can see. And here you can find many blogs. And these blogs are written by many eminent gynecologists across India in various topics. And here you can find different awareness blogs also, like PCOS, menopause, GDM, and each and every tab you will find all the relevant information on that. Like if you move this PCOS, and then you will find all the things related to the PCOS, all the talks related to the PCOS. Likewise, in case of this menopause tab, you will find all the related information on this menopause and awareness. And the most important thing is our key opinion leaders. So presently, more than 700 doctors are currently supporting us, this knowledge sharing initiative of Shield Healthcare. So now it's time to start the session with Madam, and it's my honor to introduce Madam. Madam has more than 26 years of experience in this field, and she is the senior consultant gynecologist and obstetrician. And Madam is the secretary Indore Obstetrics and Gynecology Society. And in terms of interest, Madam has a keen interest on this ethical and medical legal aspects of obstetrics and gynecology. And Madam has keen interest on the publication and in academic also, and she published many papers and conducted various educational and awareness campaigns. Apart from that, many membership with Madam, that is a member of IAEC 2019 to 21, member study of female breast committee, member of practical obstetrics committee. I am a representative for the MTP committee. Madam was the treasurer AICOG 2022. She was the coordinator medical legal workshop AICOG 22 and editor medical legal workshop manual AICOG 2022. And Madam is the editor IOGS Connect 2021-22. She was the treasurer IOGS 2019-20 and management committee member of Indore Obstetrics and Gynecology Society since 2009. And also she is many lectures and many things as an invited lecturers in many national and international conferences as well. And in terms of awards, Madam received many awards. Out of that, few awards, obviously I should mention: recipient of prestigious Wonder Foxian Award 2019, recipient of Indore IMA Corona Warrior Award by MP government in the year 2021, recipient of Corona Warrior Award on 15th August 2021 by Indore Collector, and worked for more than 8 years in various proxy committees. So with a vast experience and practical experience also, and it is our pleasure that Madam accepted our invitation to talk on this emerging topic on Shield Connect. So now it's time to hand over the session to Madam. And meanwhile, I request all the participants, please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much once again, Madam, for your valuable time on this knowledge sharing platform Shield Connect, and over to you for further proceedings. Thank you very much.
Thank you very much for the Shield Connect for giving us this good platform by connecting the various doctors and various PG students, and even many a times the other faculty members of the other fields, other branches also I saw joining this Shield Connect webinars to see the day-to-day practical topics. And this topic, which I have preferred to talk about, the menopause and practical approaches. This is a very basic topic where nowadays many times ladies are approaches to us, and we don't go in very deep in the theory, but we should know every practical aspect of that lady, what she is going through and what she wants for her treatment or for management. Most of the time it is the awareness kind of program, and every practitioner, every gynec and obstetric practitioner should know about this management aspect. And this name Prayas, this came from the Mr. Suman Sinha from the Shield Connect. I told them this is a very small effort or small step towards the awareness campaign of us. So the Prayas is a very little small effort to revise, actually to revise and to revisit that topic, not that deep one, not that theoretical one, but just to revisit that topic, the practical aspects of the menopause and its management. So thank you very much, Shield Connect, for giving us this opportunity. And thank you all the delegates who joined this webinar in the large number. So now I shall start this topic. Shall I, Sumit? Shall I start sharing my screen?
Yes, ma'am.
So this is the understanding menopause. And everyone here knows about the menopause, but as I know, there are many general practitioners who logged into this webinar. For them, the menopause is a normal, natural event. Definitely, everybody knows after cessation of menstrual cycle for one complete year, cessation of menstrual bleeding is the menopause, and it represents the permanent cessation of menstrual cycle from loss of ovarian follicular function. It's owing to declining estrogen and progesterone production by the ovaries. There are many symptoms, most of the time vasomotor, psychological, and physical symptoms are prevalent in the ladies of the menopausal age group. And at least one symptom, at least in the lifetime, one symptom is presented in the lady. And most vasomotor symptoms was 21.3%, physical symptoms 91.5%, and psychological symptoms are 44.7%, or sexual. Though there are many ladies who are complaining nowadays about the sexual symptoms, but most of the time they are avoiding. So in this list, there are no sexual symptoms, but nowadays ladies are coming with these symptoms. There are prevalence of the symptoms was 47% in India, and the menopause age group in India is 48 years to 52 years. In the European country, in the America, the menopausal age group is the 52 to 55 years. What are the stages of menopause? There are 3 stages of menopause. One is perimenopause, then menopause, and then the postmenopause. Perimenopause is the time when women's life, when hormones levels begin to decline. Rest, regular periods, as well as hot flashes and night sweats are the most common symptoms of this phase. Then comes the menopause from 45 to 50 years of the age group. The period in the woman's life typically between the 45 to 50 years of the age when menstrual period stops occurring. More than 1 year when the stops bleeding, it known as the menopause. Then comes the postmenopause. A woman is considered postmenopausal once she has gone 1 full year without a period. There are 2 types of menopause. One is the natural menopause and second is the induced menopause. Diagnosis is established when menstrual cycle stops for 12 months in the absence of an organic or pathological cause. It usually occurs at the age of 45 to 50 years in India, and if it occurs before the age of 40 years, it is referred to premature menopause. Second is the surgical menopause, induced menopause. First is the surgical. The most of the time in a hysterectomy patient, in the bilateral oophorectomy patient, or if there is any cause of radiological cessation of the ovarian, and second is the chemotherapy. Exposure to any type of chemotherapy during the treatment of malignancy, then also there is the induced menopause. There is a system of staging, straw system of staging. There is a very easy system. This defines the menopausal women. They define the age of the woman in the 3 ages: reproductive age group, menopausal transition, and the postmenopause. It depends upon the FSH and AMH level, and it is just for the practicing purpose. Dr. Anklesheria started this straw terminology just for our practical purpose and for management of the menopause. There are circulating estrogen are low, ratio of estrogen and estrogen to androgen low, sex hormone binding globulin secretion low, peripheral endometrialization of DHEA2 estrone is increased, and there is no significant change in testosterone levels. This is a chart showing the estrogen loss and manifestation of health risk over the time. Most of the time, estrogen loss and in term of hot flushes. In the age of the perimenopause to the postmenopause, the first and most evident sign and symptom is the hot flushes. Mood, sleep, and acute cognitive changes, urogenital symptoms, skin changes, cardiovascular diseases, osteoporosis, cognitive decline like Alzheimer's disease. These are some uh, symptoms and signs to be taken care. And now this is the Cooperman Index. The Cooperman Index is the combination of self-report and physician's rating. There are few symptoms who are rated as 1 to 12, 1 to 12. First is the vaginal dryness. Second is the hot flushes and night sweats. Third is the paresthesia, then insomnia, then nervousness, melancholia, dizziness, fatigue, arthritic pain, formication, palpitation, and headache. So, whenever we come across some symptoms, do ask the lady about her menstrual cycle, about her siblings' menstrual cycle, about her mother's menstrual cycle, because most of the time, the mother, daughter, or patient and her sisters, they are having the usual type of menstrual cycles. These are the menopausal symptoms which we very frequently come across. Some of the classical symptoms, there are change in the menstrual pattern, some vasomotor symptoms like night sweats, some vulvovaginal symptoms like dyspareunia, other symptoms sometimes associated with menopausal sleep disturbance and sweats, and then cognitive concerns like memory concentration, then psychological symptoms like depression, anxiety, and moodiness. There is recurrent transient episodes of flushing by sensation of warm to intense heat on body and face. As many as 75% of perimenopausal women in US have the hot flushes. Treatment based on the symptom severity and a woman's risk and personal attitude about menopause and medication. There are many patients who come to us for the sleep disturbances. Peri and postmenopausal women sleep less, and perceived decline in sleep quality may be attributed due to nocturnal urination. There are many sleep-related disorders like apnea, chronic pain, depression, stress, negative mood, ovarian hormone changes, hot flushes can trigger awakeness in the first half of the night. But REM in the second half suppresses the thermoregulation, thus hot flushes. Decision on whether or how to treat with behavioral or drug therapy of both depends on the severity of the sleep disturbances, context of the sleep problem, severity of the daytime consequences. There are many cognitive changes. Midlife women should be counseled that memory and concentration problems are probably not related to menopause, but they're rather to normal aging or mood, stress, or other life circumstances. Because the 45 to 50 years of the age group, this is the most vulnerable age group when your kids are going to make their future, your in-laws are aging, your parents are aging, even you are also aging. So there are lot many factors. They are going to disturb your concentration, going to disturb your memory, and women most of the time correlate them with the menopause. But this is not the true fact. There are many other facts which are related to the memory changes or concentration problems, not only the menopause. Feelings of upset, loss of control, irritability, fatigue, and blue moods, dysphoria at midlife may be caused by fluctuating hormone levels that perturb neural system transiently. There are many mood disorders. Women with a history of premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, or hot flushes are more vulnerable to depressive symptoms. The most predictive factor for depression at the midlife and beyond is the prior history of clinical depression. If you are already unhappy with your life, you are already going through some stress, if you are going through some tension about your career or your family, then this mood swings and mood disorder more prominent in the menopausal or perimenopausal age group. Relaxation and stress reduction techniques, antidepressant and counseling or psychotherapy are options to consider in symptom management. Then there is the chances of the abnormal uterine bleeding. Heavy menstrual bleeding, average more than 80 ml, especially with clots. Menstrual bleeding lasting more than 7 days and longer than usual. Interval less than 21 days. Any spotting or bleeding between periods, bleeding after sexual intercourse. Vaginal atrophy illustration. Vaginal atrophy is illustrated by contrast of vaginal epithelium in a well estrogenized premenopausal state, left panel, with a low estrogen postmenopausal state, which is a right panel. You can see the difference. This is just a flat surface in the low estrogen postmenopausal stage. So the skin is becoming thin, and the most of the time patients are complaining about the dyspareunia or scratches or cuts in the vagina during sex, or even during constipation, or even during ablution. Also, some patients come and said there are going to be they see the cut or they see the scratches in the vagina. Urinary symptoms common in midlife women, but menopause-related estrogen loss identified. Over 50% of women more than age of 50, they come across the incontinence. Also report severe overactive bladder. Mild incontinence in early perimenopausal age tends to decline in the first 5 years of menopause. Weight loss for overweight women. Kegel exercise can cure more than 50% of cases of stress incontinence when performed regularly, and several medications are approved for OAB. Now, there are sexual issues generally increases with aging. Distressing sexual complaints peak during midlife, ages 45 to 64, and are lowest from age 65 onwards. There are decreased estrogen causes a decline in vaginal lubrication and elasticity. Decreased testosterone may contribute to a decline in sexual desire and sensation. And active sex life, lubricants, and the moisturizers and local vaginal estrogen help maintain vaginal health. You can contact your gynecologist or your physician, who can tell them about the different postures about the sex or other things. So the female or the counterpart of means their partner, usually they complain about the boring sex life. You can guide them to a counselor, and they can counsel them there very well. Apart from the lubricants and moisturizer or the estrogen patches, everything you can suggest them, and you can suggest them to go to the counselor also. Atrophic vaginitis, definition and incidences. Atrophic vaginitis, sometimes called vagina atrophy, is a chronic progressive, occurs mainly in the postmenopausal woman, and is characterized by pale, shining, shrunken, atrophic vaginal epithelium. In addition to vagina, the atrophic changes also affect the urinary tract because their common embryological origin. The condition develops slowly, and it takes 5 to 10 years after menopause. Atrophic vaginitis affects 50 to 60% of the postmenopausal women, and then only 25% take the medical advice. It may occur in women at childbearing period after delivery or with the breastfeeding also. There are bacterial or fungal vaginal infection, and there may be cracks in the vaginal wall, dyspareunia and bleeding after the intercourse. This is the most annoying symptom for that the couple comes to us. Okay, bone health and menopause. There are many bone health issues. There are multiple fracture risk, bone pain. There is, due to the estrogen depletion, there is the impaired calcium and vitamin D absorption, and that increase in the osteocalcin, and ALP decrease in the BMD. Osteoporosis defined as the compromised bone strength. It is a serious health threat for the aging postmenopausal women by increasing risk of fracture. Lower estrogen level accounts for about 2/3 of bone loss during the 5 to 7 years around the menopause. Definitions based on the BMD results: normal, T-score greater than or equal to 1, low bone mass osteopenia, T-score between -1 to 2.5, osteoporosis, T-score less than or equal to 2.5. Osteoporosis risk factors are with the advanced ages 50 to 90, parental history of fragility fracture, female sex, current tobacco smoking, weight, long-term use of the glucocorticoids. Height, rheumatoid arthritis, low femoral neck BMD, prior fragility fractures, alcohol intake, more than 3 units daily. Other causes of the secondary osteoporosis like consumption of the steroids, uh, other few autoimmune diseases and taking treatment for the autoimmune diseases. One glass of beer, 285 ml, or one measure of spirits, 30 ml, or one medium-sized glass of wine, 120 ml, or one aperitif of 60 ml. These are the units of the alcohol intake. CVD, including CHD and stroke, is second leading cause of the death amongst the women of 45 to 64 years. Leading cause of the death for women of the menopausal age group. CHD death rates in the younger women ages 35 to 44 are increasing for the first time in 4 decades, secondary to obesity, diabetes, and hypertension. Cardiovascular health, total cholesterol should be less than 200 milligram, HDLC at least 50 milligram per deciliter, and LDL is less than 100 milligram per deciliter. PP should be less than 120 to 80 milligram untreated. Fasting blood glucose should be 100 milligram per deciliter, less than 100 milligram per deciliter. BMI should be less than 25. The patient should not be a smoker, chain smoker, and should not consume the alcohol more than 3 units. Physical activity more than 150 minutes per week, moderate, more than 75 minutes, vigorous, or both. She should take the healthy diet, healthy vegan diet, healthy non-veg diet, anything healthy, less carbohydrate, more protein, less oil and ghee. This is the very important thing. Cancer is not associated with the menopause. Menopause is not associated with the increased cancer risk. But because cancer rates increase with the age, and cancer is the second leading cause of the death in women, screening of some cancer should be done, like breast cancer, endometrial cancer, ovarian cancer, cervical cancer, and screening not necessary less than 65 with 3 or more normal pap test in a row, no abnormal pap test in last 10 years, or 2 or more negative HPV test in past 10 years. So there is no necessity to take fear for this cancer. One should go once you have extending towards the menopause, in the age of perimenopause age group, or at the time of the menopause, you should advise your patient to go for this screening, and once they screen negative for the test, then follow this protocol. If the consecutive 3 tests came negative, the tests come negative, then don't bother. Just tell them to visit you frequently, not frequently, tell them to visit you yearly. Now there is the role of hormone replacement therapy. There are many types of tablets, patches, and cream available, and that replace the estrogen that ovaries no longer or working or after menopause. Hormone therapy may have either estrogen or estrogen plus progesterone. Generally, use of HRT for a short period of 3 to 6 months been devised. Reduction of dosage should be done as soon as possible. Indication of the HRT: if the patient is having a much menopausal symptom and her day-to-day activity is suffering, and if she is a working woman and her work is suffered, and if she is not concentrating on her work, then you can assess by the Cooperman index or by the straw index, and you and the patient, they are the better judge to whom to start the HRT. Relief of the menopausal symptom, prevention of the osteoporosis, to maintain the quality of life in menopausal years, especially group of the women whom HRT should be prescribed. In the premature ovarian failure, gonadal dysgenesis, surgical or radiation menopause. If you still have your uterus, have not had hysterectomy, then you need a treatment that combines estrogen and progesterone. Estrogen alone is suitable for women who have had a hysterectomy. Vaginal estrogen therapy is useful for women who have local symptoms such as vaginal dryness. So, in the first category, estrogen plus progesterone. In the second category, estrogen alone. And in the third category, only the vaginal estrogen therapy. There are few risks of the hormonal therapy: endometrial cancer, venous thromboembolic disease, breast cancer, ovarian cancer, CVA, lipid metabolism, hampering of the lipid metabolism. There are many cases with the intact uterus and without investigation, some patients started upon the HRT, and there is the increased risk within 1 to 2 years after initiating the hormone therapy. Increased breast density with progesterone proliferation of the estrogen dependent neuron, making it more difficult to detect the breast cancer with the mammogram. There are more than 10 years estrogen therapy. It leads to many patients leads to ovarian cancers. The commonly used estrogen are conjugated estrogen, 1.25 milligram per day. Progestin used are the medroxyprogesterone acetate. Considering the risk of hormone therapy, there is a lowest effective dose and for very low time. Low dose of the oral conjugated estrogen, 0.3 milligram daily, is the effective and has gone minimal side effects. Patient with the history of breast carcinoma, progestin may be used. It may be for the suppression of hot flushes, and the medroxyprogesterone acetate 2.5 to 5 milligram daily. There are some role of the tibolone also. Tibolone is a steroid having weakly estrogen, progesteronic, and androgenic properties. It prevents osteoporosis, atrophic changes of vagina, and hot flushes, and it increases libido. The dose of 2.5 milligram per day is given. For vaginal atrophy, there are many non-hormonal creams and patches are available, and there are many water-soluble vaginal lubricants and moisturizer are available, and women should also be encouraged to continue the sexual activity. In hormonal treatment, bioidentical vaginal preparations are more effective than the oral preparations or the transdermal preparation in relieving the manifestation of atrophic vaginitis. Bioidentical vaginal estrogen requires lower doses than the systemic therapy, and this is the treatment of choice for these women. Bioidentical vaginal estrogen therapy is available in many forms like suppositories, rings, creams, and tablets. The treatment should be individualized, and cafeteria approach, there should always be the individual approach. Every patient is having the, out of that 12 to 13 symptoms, every patient is having the different symptoms. So you have to decide which symptom is the prominent and what treatment should be given. Soya, phytoestrogen, and black cohosh. This is the Cochrane findings. Increased interest in the soya isoflavones, though this is the weaker estrogen supplements, and if some patient is taking it in the reproductive age group, then only it works. If once the menopause established, then whatever amount of soya protein you will take, there is no use. No conclusive evidence of improvement in menopausal symptom in 43 trials. The meta-analysis of black cohosh reported insufficient evidence to support black cohosh for the menopausal symptom. Thus, isoflavones are not a suitable alternative in hormonal therapy. There are many products which are coming with the soya isoflavones, though they are good as a nutritional support, but they are not good for the menopause symptom cure. There is insignificant result. These are some trials. There are few herbs, Sinecum wildofordi, Phlomis ambrosa, Angelica gigas. They are very costly herbs, and many pharma companies come with these herbs products, but on many trials they are of no use. Efficacy and safety of nutraceutical on the menopausal symptoms in postmenopausal women. This is the double-blind randomized placebo-controlled clinical trial, and there is no significant findings about the relief of the menopausal symptom. So, Only one thing left, the lifestyle management. There is the therapeutic lifestyle management, physical activity and targeted exercises, nutrition, avoid the alcohol and tobacco consumption, stress reducing strategies, meditation and paced respiration, massage and hobbies and nutrition, emotion stability, positive attitude, family involvement, spiritual attitude, and sleep. Living with the menopause with balanced and nutritious diet. This is a diet chart. Cut the carbs, cut the milk and milk products, increase your fruit products. One of my classmate always says, the product whichever come from the factory, avoid them. Product whichever come from the fields and from the trees, try to consume them. So take the balanced diet, take the nutritious diet, and enjoy your menopause. Recommendation of sugar 6 tablespoons per day, salt 1.5 tablespoon to 3 to 5 grams per day, oil only 2 levels of tablespoons, fruit 100 grams per day, and there should be 3 colors in your platter: yellow, orange, and green. Try to consume 3 fruits of 100 grams. Though 2 pieces of every fruit, that will also go. Or one day one fruit, the another day another fruit, and the third day the third type of fruit. Vegetables 300 grams per day. Drink 8 glasses of water every day. Add powdered flaxseed, cinnamon, fenugreek, soap in salads and curds. Avoid more than 200 milligram per day caffeine. Limit intake of tea or coffee to 3 cups a day. 1 cup of 150 ml of brewed coffee is equal to 120 milligram of caffeine. 65 milligram for 1 cup of instant coffee and tea. Consume a minimum of 500 to 600 milliliter of milk or curds, and that also the low fat or without fat. Skim milk curd, you should prefer the skim milk curd. Support it with the lots of vitamin C rich fruits, vegetables to favor the calcium absorption. The recommended dietary allowances of calcium and vitamin D for the adult Indian is more than 800 milligram per day calcium to 1200 milligram per day. Upper limit of normal is 2500 milligram per day. Vitamin D should be 1500 to 2000 international units, and upper limit of normal is 10,000. Thyroid medications, corticosteroids, tetracyclines, and anticonvulsants and calcium should not be taken in one go. Calcium always should be taken separately. So try, if you are taking you are prescribing some other drugs to the patient, then tell her to take the calcium separately with the other meal. Contraindicated in patients with the hypercalcemia and renal insufficiency, with caution in nephrolithiasis. Excess amounts more than 2500 milligram a day, it affects kidney and reduce the absorption of other minerals like iron, zinc, and magnesium. So whenever you prescribe calcium, do prescribe magnesium tablet, do prescribe the vitamin D. If the sun exposure of this patient is low, then do prescribe vitamin D and magnesium with the calcium. Management of the vitamin D deficiency. Vitamin D3 tablet or powder 60,000 international unit once a week for 8 weeks, preferably with hot milk at night time, or 1 intramuscular injection of 6 lakhs international unit is given to correct the deficiency. Maintenance therapy from natural sources or supplement is advised after correction of the deficiency. Now, managing the thromboembolic risk with menopausal hormone therapy in the COVID-19 pandemic. This is the confirmed COVID-19 women using MHT. Hospitalized patient should withdraw the systemic MHT, LMWH at the prophylactic doses, and then after the full recovery, she should continue this. In outpatient department, if there is some mild COVID-19 symptom, then also withdraw MHT or switch to the transdermal MHT. And after full recovery, after 6 weeks of the recovery period, you can start on this patient the MST. This is the very important thing because most of our population suffered in last 2 years. Most of our women population suffered from the COVID-19, and many of those population they are perimenopausal, menopausal, or postmenopausal age group females. So they should know when to use the MST. Infusing MST switch to transdermal MST at the prophylactic LMWH is necessary. So everybody should know to stop the MST in the COVID-19 symptoms. Conclusion is the women live 1/3 of their life in the postmenopausal period. Perimenopausal and postmenopausal women may be affected by the symptoms condition associated with the hypoestrogenol like vasomotor symptoms, vaginal dryness, and osteoporosis. In most women, hot flushes usually resolve without treatment. As HRT have its severe drawbacks, non-hormonal management is the best treatment in the menopause issue. Complementary and alternative medicine is an efficacious treatment strategy. Eating the right diet along with the supplements, having adequate sleep, exercising regularly can lead a blissful postmenopausal life. Before giving you a thank note, I should add one thing which uh, by default I missed this thing: vitamin E supplementation. Your cardiovascular risk will decrease by taking the 600 milligram of vitamin E. This is the established fact of taking vitamin E in the postmenopausal women. So, with the calcium and vitamin D supplementation, you should prescribe vitamin E also to the patient because lack of the antioxidant effect of the estrogen after menopause that decreased HDL resistance to oxidation and impaired antioxidant ability, and that impaired ability of the HDL to protect the LDL against oxidation, then that increased the LDL oxidation and that enhanced the atherosclerosis. And there is the increased risk of the cardiovascular disease. The postmenopausal woman has a 1 in the 3 chance of developing CVD due to the impaired antioxidant HDL activity and increased LDL activity. So one should prescribe them the vitamin E in the adequate dose. Vitamin E administration caused a significant 24% reduction in CVD deaths in the Women's Health Study. There are 3 studies. There are 3 double-blind studies which says vitamin E modulates the endothelial dysfunction by several mechanisms and prevents atherosclerosis. I missed that particular slide. And I misread this slide. So that's why I'm just telling you to add 600 milligram of vitamin E in your diet for 3 months when you are prescribing the vitamin D, magnesium, and calcium to the postmenopausal women. Please do add vitamin E also. It also maintains the vascular function. It improves the fibrinolytic activity, decreases the oxidative stress, prevents atherosclerosis progression. This is the take-home message for everyone. So take your diet properly, take a balanced diet, take proper sleep, indulge yourself in some hobby, indulge yourself in the exercise, especially the weight-bearing exercise, not simple walking. You should start doing the weight-bearing exercises also, and follow some hobby because the khali dimag shaitan ka ghar hota hai. And if you are not having that much of symptom, you should tell your patient. If she is not having that much of symptom, but if she is sitting idle, then she will stress more, she will think more. If she talks to another female and about the hot flushes or about the sweating or about the apnea or sleep apnea or disturbance in the sleep, she should also feel कि ये मुझे भी हो रहा है. So try to tell your patient to indulge in some fruitful hobby or eat right, exercise right, and enjoy the postmenopausal time. Thank you. Thank you very much.
Thank you very much, madam, for such a nice deliberation. Just give me 1 minute time, madam, to check the questions in our dashboard. Madam, one thing, this in case of cognitive decline in postmenopausal women, how can you tackle that?
case of cognitive decline.
Yes, madam.
Yes. Just a minute. There are, though this is a cognitive, in the first symptom, when patient come to us, there are the sleep disturbances and continuous sleep disturbances, and the women has to work day and night. So once she started, she is not having the proper sleep and started working in the daytime, and this is a vicious cycle. And then when the after the 10 years of the menopause, this particular type of Alzheimer's or this is, setting in, you have to tell her to go to a counselor to take some rehabilitation treatment, some go to see a physician to take some medicines, and give her a proper environment, happy environment. Why our old females, our old generation, they are having a very good memory, they are having very good speech, good memory, good everything good. We are having our dadis and nanis of 80 to 90 years having, they revise everything very properly because they are having very healthy atmosphere at home. So try to tell the patient to meditate, to again and again repeat the things. If she falls short to remember something, tell her to do some exercises, some learning exercises, and to do some yoga and meditation. And if still the condition worsens, they do see the physician also for the treatment. Especially in the later age, nowadays many females are coming with the Alzheimer's disease. So first symptoms, you have to pick the very first symptoms. The very first day when you uh, fall to remember where your car keys are, where your sarees are, where you put your jewelry. The very first day when you fall to remember this thing, you should be in the alert mode for the patient, for yourself also.
Thank you very much, madam. And in case of ma'am, early menopause, in case of oophorectomy
Suman,
or
can you speak louder, Suman?
Yes, yes, ma'am. In case of surgical menopause, what will be your practical approach on that?
Yes, I told you. In the surgical menopause, you can give the estrogen only pills also, patches also, lubricants also. In surgical. When the
Thank you
uterus
very
is
much.
not intact, when the uterus is not intact, you can give the estrogen.
Thank you very much, madam. Another doctor, we have received one appreciation also from Dr. Shweta Kolja, madam. Madam told that nice initiative. So I could not find any other thing, ma'am. So if you allow me, then we can conclude the first session on this.
Just actually, most of the time, our gynecologist or our general practitioner, they do prescribe everything once the menopause is established. But we have to take care of these women. The age when they come into the perimenopausal age, at the age of 45 to 50. Once everything is depleted, you cannot make the stores as pretty as the previous one. You have to start everything at the age of 45. If you start vitamin D, if you start vitamin E or everything, if you start anything, you should start at the age of 45.
Thank you very much, madam, for this nice deliberation and for addressing all these queries. So thank you very much once again for such a nice session on this emerging topic. And obviously in our first session in our webinar series,
yes, this is also my first session with you. This is really a good prayas from my and your side. And I am really very thankful to the Shield Connect for giving me this platform to connect with more and more doctors and more other doctors other than the Gynec Society. I am really thankful for Shield Connect and looking forward.
Thank you very much, madam. And obviously, thank you very much for all the participants for your patience. And soon, hopefully, within 2 weeks of our next session will be madam will be soon. So please stay tuned.
Actually, this is not a very this is just for the revision of our day-to-day practical approach. This is not a very theoretical or not very, this is not as exam going PG students presentation. This is just for revision of our practitioners, what to do, what not to do. So
Thank
I'm
you.
looking forward for the another good topic.
Yes, yeah, obviously. Thank you very much, madam, for such a nice
Thank you.
discussion.
Thank you very
Thank you. Have a good day, madam. Thank you.